Good evening and welcome. I'm Nora Kane and I'm the director of the Stanford Health Library. And it's my pleasure to welcome you this evening for the first in a three-part series on reproductive recurrent pregnancy loss. This is a subject that I think is going to be of great interest to many people. And we're very happy that we're able to present it as a three-part series. And this is the first one this evening. It is my pleasure to introduce Dr. Ruth Lathi, the professor of Obstetrics and Gynecology and Reproductive Endocrinology and Infertility at Stanford Medical Center. Dr. Lathi graduated from Massachusetts Institute of Technology with a BS in molecular biology, and she earned her MD degree at the University of California in San Francisco and completed her residency training in obstetrics and gynecology at Baylor College of Medicine. She completed her subspecialty fellowship training in reproductive endocrinology and infertility at Stanford University. Dr. Lathi joined the faculty at Stanford University in 2003 and is currently a professor in the Department of Obstetrics and Gynecology and director of the Multispecialty Recurrent Pregnancy Loss Program at Stanford. And she is the program director of the RAI Fellowship. Dr. Lathi has a special interest in treating recurrent pregnancy loss, the role of pre-implantation genetic diagnosis in the treatment of reproductive disorders, and the prognostic value and utility of genetic testing of miscarriage issues and long-term outcomes of fertility treatments. It's really a great pleasure to welcome you this evening, Dr. Lathi, and the rest of your colleagues who will be speaking with you tonight. Thank you.
Thank you so much, Nora and Amy and the Stanford Health Library for sponsoring this program and giving us a chance to share our program and hopefully share some knowledge and hope for our patients and our families who are interested in learning more tonight about repeat pregnancy loss. I'm going to share my screen. I have a few introductory slides, and then we will move on to some of my colleagues who will be speaking as well tonight. So let's get started. So tonight we're, as Nora mentioned, kicking off a series, three-part series to help share some knowledge and information about the subject of pregnancy loss and repeat pregnancy loss, and what some of the innovations and treatments that might be available to our patients as they move through their journey. Tonight, we're focusing primarily on our multi-specialty approach. Why do we need a multi-specialty approach to miscarriage, and who is involved in this program? On the second part of the series, we're going to be talking about some of the research we're doing and things that we're doing to try to help answer some of these unanswered questions in fertility and pregnancy loss, and how patients, if interested, might want to get involved in some of those projects that we're working on. And then lastly, a very important part of our pregnancy loss journey is just the emotional journey. How to navigate this very difficult journey to starting our families, and how we can move forward together. So just want to give a few topics, a few introductions about what are we talking about when we talk about pregnancy loss. What's a miscarriage? What's a pregnancy? And after being an OBGYN specialist for now 25 years or so, still this question comes up. Was I pregnant? Was that a pregnancy loss, or was that a miscarriage? And what I want to share with you all tonight is just what we call the pregnancy pyramid, meaning that a very small minority of pregnancies and conceptions that begin actually progress all the way to a live birth. So starting from the moment of conception or fertilization, we know that about 30% of conceptions don't even implant in the uterus. The egg and sperm meet, they start to divide, and then they don't attach properly. Another third will implant briefly and then miscarry before they can be clinically recognized. And in medicine, we consider a clinical pregnancy something where the menses is delayed, or the period is delayed significantly, and we can see a pregnancy on ultrasound. So that's considered a clinical pregnancy. And then of the 40% that make it to clinical pregnancy, only about 30% total will actually make it all the way to be a live-born baby and a human that enters this world walks and talks and laughs and crawls and things. So we know that there's a lot that we have to learn about why this huge drop off from fertilization to live birth, what's happening there, and that's why we're here, to learn more about why these pregnancies don't all make it, what's happening there, and what we can learn from our studies. Now, you'll hear terms this evening and throughout our series about pregnancy loss and miscarriage. And a lot of times people will get those two terms confused or overlapping. A miscarriage is really the loss of a clinical pregnancy, or a pregnancy that we can see clinically and then is lost. And that usually happens in the first 3 months. That's really what we call a miscarriage, something that happens between clinically recognized pregnancy and the beginning of the second trimester. When we talk about pregnancy loss in general, this could include preclinical losses and really a pregnancy that may or may not even be recognized, and potentially even a pregnancy that's lost after that second trimester. So the umbrella term is pregnancy loss. Miscarriage is a very specific term within that term that indicates a clinically recognized event that happens where a pregnancy starts off and doesn't make it to birth. Pregnancy is not simple. When we see children born in this world, we say, oh, that looks easy for so many people. But in reality, for a pregnancy to be successful, there has to be a lot of systems that have to be healthy and in balance for everything to go correctly. So a failure of any of these systems could lead to pregnancy complications or pregnancy loss or miscarriage. So when we talk about endocrinology, we're talking about hormones and being in balance and supporting the pregnancy throughout. Genetics have to be healthy. The hematologic system, the immunologic system has to be healthy. There also, the male partner has to be healthy. And there are a number of other specialties that really play into preparing the body and the family for pregnancy, and then getting that pregnancy all the way to term. So this is why we built our team. So our recurrent pregnancy loss team includes 25 members. We founded this program in 2009, and it's really been a delight to work with several of these members throughout the last 12 years in building this program and working on some of these challenging problems associated with pregnancy loss. We meet regularly, we discuss updates in the field, and we really collaborate on some of these complex problems to help our patients realize their dreams of having a successful pregnancy. So although we can't have everybody speak to you tonight, we chose a handful of our team members to just give you their perspective and their approach to pregnancy loss based on their individual specialty. So we're going to start tonight. The first speaker will be Dr. Heather Byers from Genetics, and we'll talk about genetic causes of pregnancy loss. We have Dr. Aghajanova from Fertility, who will be speaking to us about the uterus and how that can help a successful pregnancy. Dr. Chin from Hematology is going to help answer some of your questions about blood clotting and blood thinners and pregnancy loss. And Dr. Eisenberg from Urology will talk to us about the important role of men's health and pregnancy success and miscarriage. Lastly, I'll save some time at the end for questions and answers. You may have questions throughout the evening, which you can put in the Q&A box, or you could save them to the end. We'll save some time to the end. We'll try to answer as many questions as possible. And if we don't get to your question, we will ask for an email if you'd like us to email you a response to the questions that we didn't get to, and Nora will help us coordinate that for us. So without this, and additionally, if you get called away during this session or you miss one of our sessions, we will record these 3 sessions for you, and you can always access them later through the Stanford Health Library. So it's my pleasure to turn over the stage to Dr. Heather Byers, who has a very special interest in the genetic causes of pregnancy loss, and will give you some of her insights to our disorder.
Thank you for that introduction, Ruth, and thank you all for joining. My name is Heather Byers, and I'm a medical geneticist with expertise in perinatal and reproductive genetics. I'm going to talk with you today about the genetics of recurrent miscarriage. My talk will focus on the fundamentals and what is established in the genetics of recurrent pregnancy loss. By the end of tonight's talk, I hope you'll better understand the underlying basis of how genetics can contribute to recurrent miscarriage. Risk factors for genetic abnormalities, including age and structural anomalies, and testing options for couples with recurrent miscarriage. To make sure we're all on the same page before we get started, I'll briefly review genetics. Genetics material is the code that tells your body how to grow, develop, and function. This code is called DNA, and it's packaged into genes that are located on chromosomes. The code is present in nearly every cell in your body. We inherit half of our genetic material from our mother and half from our father. When sperm and egg meet, this forms a zygote, or a single cell that goes on to develop to 2 cells to 4 cells to the billions of cells that are present in a term infant. The genetic abnormalities that I'll talk about today are constitutional changes and present from the fertilization or zygotic stage or shortly thereafter, and therefore present in all the cells of the conceptus. Inside each of those cells are 23 pairs of chromosomes inherited from the mother and the father. The chromosomes are numbered 1 through 22 and are identical, nearly identical, with the exception of the X and Y chromosomes, the sex chromosomes that will determine if an individual develops as a male or female. On each chromosome, there are thousands of genes, and the genes are dose sensitive, meaning that the body can't tolerate an excess or significant missing portion of chromosome material. When an individual has an abnormal number of chromosomes, or what is referred to as aneuploid, this may result in a dose sensitivity that leads to a non-viable pregnancy. Smaller chromosomes with relatively fewer number of genes are more able to be tolerated as trisomies, including chromosomes 13, 18, and 21, which can result in a trisomy that can result in a live birth. The only chromosome that can survive as a monosome, only chromosome difference, where the pregnancy can survive as a monosomy, is a chromosome X in females when paired with another X. And although parents are passing on half of their genetic material to each child, they've also inherited half of their genetic material from their parents and have 2 copies of nearly all of their genes. Which chromosome is passed on is random in each pregnancy, and there can be numerous combinations that make each pregnancy and child different from another. And although human development is a consistent and methodical process, it is also an exceptionally complex process. And there are numerous stages within that process where an error can occur and impact the viability of the pregnancy. What I'm talking about today in testing for genetic causes of recurrent miscarriage is in the clinical miscarriage state, or after a pregnancy has been clinically recognized and results in a miscarriage. It's also possible that if the loss occurred very early on, even before implantation, the couple may not have even recognized that they were pregnant. The vast majority of miscarriages, or 70%, are due to chromosomal abnormalities. Non-disjunction typically occurs at meiosis 2. The stage where oocytes sit arrested until the oocyte matures and is released in a monthly cycle. Errors on maternal cells are more tolerated than meiotic errors on the paternal chromosome, and therefore when we see an aneuploid in products of conception or a fetus, it's more often derived from maternal meiotic error. Maternal meiotic errors can occur on any chromosome, but seem to be more common on smaller chromosomes, particularly when identified through products of conception. It's possible that aneuploidies in larger chromosomes likely arrest earlier, never making it past the blastocyst stage. You can see here that the daughter cells divided appropriately, but the sister chromatids did not separate, resulting in a meiosis II error. Because the oocyte, the female gamete, had two sister chromosomes, when it was fertilized by sperm, it would result in a monosome or trisomy. And here, because there were no sister chromatids, at meiosis II, when fertilized by sperm, it would result in a monosomy, both of which would likely impact the viability of the pregnancy. One risk factor of aneuploidies is maternal age. You can see here that the risk of aneuploidy goes up significantly after age 40. The blue line is showing aneuploidies detected at time of CVS, which is in late first trimester or early second trimester. It's likely that many of these aneuploidies may have resulted in a later pregnancy loss. Although individuals with recurrent pregnancy loss can still have random errors of non-disjunction, the likelihood of this occurring randomly repeatedly becomes less likely. And so when a couple has two or more pregnancy losses, part of the recommendation is to do a karyotype in the parents. One error that can occur is a chromosomal translocation. Assessing parental karyotypes in a recurrent miscarriage evaluation can identify an etiology in 2 to 5% of couples with recurrent pregnancy loss. A chromosomal translocation is when one chromosome or part of a chromosome is transposed onto another chromosome. That individual has the overall correct amount of chromosome material and therefore doesn't have any type of physical difference. Although because the structure is altered, they're referred to as a balanced translocation carrier and at risk of passing on an unbalanced chromosomal complement in a future pregnancy. And so you can see here that this individual has the overall correct amount of gray and black chromosomes. However, they are present in a balanced translocation. They're a balanced translocation because there's a structural difference in how those chromosomes appear. Therefore, when this individual will go through meiosis, or the division and separation of the chromosomes into gametes, from diploid to haploid cells, these can form, they can result in normal gametes, balanced carrier, or an abnormal number of sister chromatids, which could subsequently result in monosomy or trisomy of the different chromosomes involved in the translocation. Current genetic testing strategies for chromosomal assessment in recurrent pregnancy loss include karyotype to assess for pathogenic unbalanced translocation in the parents, and chromosomal microarray to assess for aneuploidies and copy number variants in the fetus. Together, these tests identify a genetic etiology in approximately 40% of pseudoanomalies or pregnancy losses. Karyotype and chromosome microarray can assess most known genomic abnormalities associated with pregnancy loss. However, in some cases, a chromosome microarray may be recommended over a karyotype because of the fact that a microarray does not require cell culture. Cell culture is dependent on the cells having viability, which often limits the ability to obtain a result in a karyotype from pregnancy loss. For parents, it's recommended that they have a karyotype because, again, a parent who is a balanced translocation carrier would have the overall amount of chromosome material, but it would be structurally abnormal. A chromosome microarray takes the DNA from the affected, in this case, the pregnancy loss, and compares it to a control. It then puts it through a software program and compares the amount of chromosome material. This can detect if there is an excess of chromosome material in the affected, such as an aneuploidy or a trisomy, or a deletion, a missing piece of chromosome material, such as a monosomy. Another genetic testing option for couples with recurrent aneuploid losses or known balanced translocation carriers is pre-implantation genetic screening. This involves advanced reproductive technologies such as in vitro fertilization with ICSI, biopsy and genetic analysis of the embryos, and then implantation of the embryos that are chromosomally normal. Thank you for your attention today. I touched on just the tip of the iceberg of the genetics of recurrent pregnancy loss. There's many other factors to discuss that are beyond the scope of today's talk, but I look forward to hearing about more in the upcoming seminar series. Thank you, and I can take any questions at the end of the Q&A.
Hi, everyone. I am very proud of being here today. And I am Dr. Lusine Aghajanova from Stanford Fertility, and I will be talking to you about uterine aspects of pregnancy loss. So as Dr. Lathi mentioned, pregnancy loss in general, just a miscarriage, can happen to a large number of women, and sporadic miscarriages, one miscarriage or so, can happen in about 25 to 50% of women, and that's pretty common. Recurrent pregnancy loss is a bit different story. It's not as prevalent, happens to 1 to 3% of women, but it's pretty significant problem, as we all know. So as kind of to repeat, recurrence suggests a persistent cause. So if it's a recurrent problem, it's not just a bad luck, and it needs to be evaluated. And here where we all come in. So what do? We do recurrent pregnancy loss or RPL workup. When do we do that? So classically, the classic kind of GYN approach is to do evaluation after 3 miscarriages. However, if patients are high risk, older, there is no medical issue, there is a family history, evaluation happens earlier. We as fertility specialists usually do not wait until our patients have 3rd loss, and we do evaluations after 2 losses or even earlier if special circumstances. So why do we do that? Because patients and physicians generally want to know what was the cause of my miscarriage, what is the risk of this happening again, and what can be done to evaluate and treat the problem if it's found so it doesn't happen again. Important thing to kind of remember that couple may have more than one cause of RPL, recurrent pregnancy loss, so it's good to be thorough. And as we mentioned again, there are several causes of miscarriages, of recurrent pregnancy losses. Unfortunately, still in about 50% of cases, we cannot identify a cause. And thus we have this notion of idiopathic or unexplained recurrent pregnancy loss. In about 5% of cases, the genetic causes are responsible, and Dr. Byers will still talk to you about this tonight. In about 20% of cases, anatomy or uterine issues are responsible. Endocrine causes can be responsible for about 10% of RPL. Immunological or hematological causes can be responsible for about 10% of cases, and you will hear about this today as well tonight. Infections can be responsible for about close to 5%. Something that's not here because this is a little bit old slide is male factor infertility. Dr. Eisenberg will talk to you about how male partners can contribute to recurrent pregnancy loss and what we can do about it. So let's talk about the uterus. It's really important, right? So why is it important? And the question is I usually ask, what is more important, seed or the soil? Nobody can make this choice, right? Both are important, and same thing happens in a pregnancy. We have to have a good quality of embryo, and we also have to have good uterus that's fit for getting pregnant and carrying the pregnancy. Regardless of quality of embryo, suboptimal uterus and endometrial will not result in pregnancy. Again, preconception health of the uterus of endometrium will determine health and success of pregnancy. And if you can see in this, on the picture, on the cartoon, I don't know if you are able to see my mouse, but The lighter color represents uterine muscle. The brighter red color outlines the uterine cavity, and it represents endometrium. That's the inner lining, inner layer of the uterus that's actually is participating in acceptance of the embryo, in implantation and establishment of pregnancy. Abnormal endometrium, abnormal uterus can result in infertility, recurrent implantation failure, can result also in miscarriage and recurrent pregnancy loss, and later in pregnancy can result in complications of pregnancy, such as placenta accreta, increta percreta, that can result in life-threatening hemorrhage. Preeclampsia, one of the serious complications of pregnancy, also has been tied to abnormalities in endometrium. So let's talk about anatomic causes of recurrent pregnancy loss. So let's start with congenital and common one. Uterine septum is congenital abnormality of the uterus, can be partial or complete. And as you can see again in the middle, you see our normal uterus with nicely outlined uterine cavity. And on the left, you can see this kind of invagination of a tissue inside the cavity. This tissue usually is representing scar tissue, and it's poorly vascularized. So if the embryo attaches somewhere on it, it will not meet the needed vascularization kind of requirements, and the early pregnancy loss will happen. So what we do, we perform hysteroscopy when we go with a camera inside the uterus, and under direct visualization, we basically just dissect and remove this scar tissue. And this treatment usually is quite effective. So now the next acquired anatomic problem that we deal with are endometrial polyps. Endometrial polyps are so-called outgrowths of endometrial tissue, and I usually compare them with skin tags just inside the uterus. As you can see on the upper panel, this is how the normal uterine cavity looks on saline sonogram, which is a diagnostic test that we do when we try to evaluate the cavity. And you see how nicely cavity is outlined. There's nothing coming inside it. Endometrial polyps inside the uterine cavity, this is how they look. Right, and then when we identify them, we perform hysteroscopy again and remove those polyps. And again, this treatment is quite successful. Another uterine pathology that we are looking for are submucosal or intracavitary fibroids. So fibroids are pretty common benign tumors of the uterine muscle. They are present in probably even 50% or more of women out there. And if this kind of fibroid or this benign tumor grows into the cavity of the uterus, that can be associated with recurrent pregnancy loss. So what we do, we perform hysteroscopy and remove those intrauterine fibroids. And again, this treatment is pretty successful. Another acquired anatomic issue is intrauterine adhesions or scar tissue inside the uterus. This pathology often happens after various intrauterine manipulations, surgeries, or DNCs for miscarriages or after delivery, or can happen after severe infections. So what happens that the uterine layer becomes, including stem cells in the endometrium, becomes damaged, so it cannot grow well and is being replaced with scar tissue, and hence the establishment of pregnancy or normal development of pregnancy is disturbed, and it can result in pregnancy loss. What do? We perform hysteroscopy and try to remove the scar tissue. In majority of cases, we are successful. In some of the cases when the scarring is really severe, the treatment can be a bit complicated. Okay, so, and I think the last one in these anatomic issues that we can deal with is more of the congenital abnormalities of the uterus. So, and on the lower part of this panel, on the right side, you can see our friend normal uterus with normal cavity. And then on the lower part, you see arcuate uterus, which is a variance of norm. It has just a little bit small invagination of the this top part of the uterus inside the cavity, is not really associated with a pregnancy loss. Septate uterus we talked about already, and on the top part, we see congenital uterine anomalies, inborn anomalies. So you can see that unicornuate uterus represents only 1/2 of the uterus. Bicornuate uterus has both halves of the uterus and one cervix, but kind of, almost basically 2 uteri. And didelphous uterus has 2 uteri horns and 2 cervices. So these pathologies are not extremely common, and they can be associated with earlier miscarriage, but most commonly they are associated with later miscarriage as well as preterm birth. So there is no, currently the surgical treatment is not an acceptable therapy for this, and conservative management and close observation during pregnancy is the way to go. And here you can see, sorry, I'm going back. Here you can see just nice 3D ultrasound scans of normal uterus, unicornuate uterus, didelphous, bicornuate uterus, septum. What else can we check in the uterus to ensure that we evaluated you to the best of our ability? So chronic endometritis has been lately associated with recurrent pregnancy loss. That's the chronic asymptomatic inflammation of the endometrium, of this lining of the uterine cavity. Can be diagnosed with endometrial biopsy and the specific staining of tissue. And here where, our pathology colleagues actually play a big role. The treatment is with antibiotics, and some patients may require repeat courses, so we have to stay optimistic. Treatment is associated with improved outcome and live birth, so it's worth proceeding with this. A lot of microbiome studies are done recently, and presence of lactobacilli in uterine cavity also are considered to be important for successful pregnancy. So therefore, to make it simple, our recommendation is to test uterine cavity for all women with 2 or more miscarriages. And the modality of testing, saline sonogram, hysterosalpingogram, or hysteroscopy can be decided with your physician. We do recommend repeat testing after each miscarriage or annually to assess for acquired anomalies. Here is just kind of piece of good news for everyone, that the chance of future success in terms of live subsequent pregnancies is actually quite high, even if you have 3-4 miscarriages. So even if you look at age 35, 5 miscarriages, you still have 60+% chance of your next pregnancy being successful. Thank you very much. I'm going to stop here. You're very welcome to submit your questions to the chat, and we will try to address them all at the end. And now, next it will be Dr. Mei Chen from Hematology talking to you.
Thank you all. It's a pleasure to be here this evening. My name is Mei Chen, and I'm a hematologist at Stanford. So what does a hematologist do in recurrent pregnancy loss? Well, a hematologist, we specialize in blood disorders, and we get consulted whenever there's a concern for abnormal clotting or bleeding. So when you come to my office, or nowadays our Zoom evaluation, we actually spend the majority of time getting a very thorough history of bleeding, of blood clots, and family history of bleeding and blood clots. Because the more we learn about recurrent pregnancy loss and clotting disorders, we realize that personal and family histories really influence how we manage and treat patients. So although the actual clotting and bleeding issues don't make up a huge portion of recurrent pregnancy loss, one of the main issues, the most common disorder that I deal with as a hematologist is antiphospholipid syndrome. So that's a little bit of a mouthful, but I would characterize antiphospholipid syndrome as an acquired autoimmune condition. So your body is supposed to be making antibodies to fight off foreign entities like a virus, but instead gets confused and starts to fight off self. The main manifestations of antiphospholipid syndrome are, in addition to blood clots, recurrent miscarriages. So the reason why we get involved, why hematologists get involved, is that the diagnosis of antiphospholipid syndrome is pretty tricky. There are pretty complex clinical criteria, which I've listed, but in short, it is recurrent pregnancy loss, things like eclampsia and preeclampsia, as well as a personal history of thrombosis. There are also laboratory criteria, and I can already tell from the audience that this is a very astute audience. So you might have heard of things like the lupus anticoagulant, cardiolipin antibodies, or beta-2 glycoprotein antibodies. To make the diagnosis of antiphospholipid syndrome even more complex, in order to appropriately obtain these laboratory tests, it's not difficult. It's difficult to draw, it's difficult to run, and then most difficult to interpret. So whenever I am considering a diagnosis of antiphospholipid syndrome, I do actually think that it is a good idea to get those labs drawn at Stanford. Labs done at other places are prone to false positives and false negatives, which can make this diagnosis very challenging. So I always insist that patients come to the Stanford lab to get those lab drawn to be as most accurate as possible. And the reason why we fuss over these labs so much is that a diagnosis of antiphospholipid syndrome does change our management and does require a blood thinner, which I'm going to get to a little bit more on the next slide. But before that, I've talked a lot about antiphospholipid syndrome, and you may be thinking, what about the other inherited causes of increased, propensity for blood clots? You may have heard of things such as factor V Leiden, prothrombin gene mutation, protein C, protein S, antithrombin deficiency. A lot of these inherited reasons to have, or a thrombophilia, increased predisposition to a blood clot, these were in the past thought to have a much more important role in recurrent pregnancy loss and were widely screened for and widely tested. But as we now know, it's really the personal and family history that has an even larger role. So so many of these conditions are no longer routinely screened for unless there is a significant personal or family history. So my next topic is a little bit scary. Do I need shots? So low molecular weight heparin is an anticoagulant or a blood thinner that it is administered through daily shots. And it is true that with the diagnosis of antiphospholipid syndrome, low molecular weight heparin has proven clinical benefit. So we do put our patients who are diagnosed with antiphospholipid syndrome on daily shots of low molecular weight heparin. The good news is that this diagnosis is rare, and there are very, very, very few other indications where a blood thinner or an anticoagulant is needed. So for the most part, you will not be needing daily shots. Now, you also may be thinking, why is she mentioning shots when there are so many new oral anticoagulants? What about the Xarelto and the Eliquis that I hear about on commercials all the time? Unfortunately, there are no oral anticoagulants that are approved in pregnancy. So if you are needing an anticoagulant, it is low molecular weight heparin. I think the last thing that I want to mention is that you may, the idea of needing shots can cause a lot of anxiety. You may be thinking that what if the blood thinners interfere with the pregnancy plan that I had envisioned? So this is what hematologists are here for. We work really carefully with anesthesia and obstetrics to make sure that patients safely are able to carry out their desired delivery plan, whether that means an epidural or not. So I am really happy to have been able to talk with you guys today, happy to talk with you in clinic or in the chat later on. And I will turn it over now to Dr. Michael Eisenberg, who will talk about men's health in miscarriages.
Thank you to all the other panelists and all for the attendees. It's certainly a very important topic, and it's very encouraging to see so many people with us tonight. So what I want to do is talk about male factor. You know, we've heard a lot about the known causes of recurrent pregnancy loss. And if we remember from Dr. Lathi's slide at the beginning, or Dr. Aghajanova's, you know, really all the causes that we know about essentially, or most of them at least, are on the female side. So I would say probably 90%. But we are learning more and more about male causes. So we'll go into that in a little bit more detail. So I think there have been some misconceptions about male fertility, and that's why I think the male evaluation has really lagged behind. The first is that this myth has flourished that women are the sole causes of infertility, and we now know that that's really not the case. Another real impediment has just been training. There have not been a lot of specialists in male reproductive health until a little bit more recently. And so as a result of that, there was just really lack of access to care. And also with the advent of in vitro fertilization, which is very, very powerful, a lot of male evaluation has been bypassed. And so with that, in addition to other causes of infertility, recurrent pregnancy loss has also been sometimes bypassed as well, at least when it comes to male evaluations. But if we look at the causes of infertility, we find actually a surprising portion is due to male factor. So here, the orange represents sole contributors of male factor infertility, and you can see that's 30%. The dark or the kind of orangish red is a combined male and female factor. So together, about half of all causes of infertility can be attributed to male factor. So it is important for us to remember the father. So let's talk a little about what's included in a normal male infertility evaluation. So just like all medical evaluations, there's going to be a history. We want to know about any prior pregnancy losses, any medical conditions, past surgeries, any treatments men have undergone, because some of those certainly can impact the ability of normal and healthy sperm to be generated. We want to do a physical examination, really focus on the genitalia, make sure all the structures are there where they need to be, assess the size, etc. A focused laboratory examination is also going to be crucial. We'll do a semen analysis to check how much sperm or how much semen comes out. We'll look at the number of sperm, motility, and some other parameters. In select cases, we'll also do a hormonal analysis. I think we're very used to understanding that hormones are checked routinely on women for fertility evaluations, but in a similar vein, we do similar ones on men as well. And then also there's selective genetic testing that's done well, and Dr. Byers will tell us a little bit more about that. And in select cases, we'll also do imaging assessments as well. So really the cornerstone is a semen analysis, and that really kind of tells us a man's potential for sperm production. So we look at the volume, how much comes out, how many sperm there are. We have these sort of minimum criteria here that I'm showing. Motility, how many are moving, and then morphology, or the shape. When we do these evaluations, we find many things. So sometimes semen analysis is completely normal. We see that about half the time. But sometimes we do see either isolated or combination of different deficits, whether it be in concentration, motility, morphology, and in some cases, even there's a complete absence of sperm. When we do the evaluation, we find many things, and some of these are actually very important for recurrent pregnancy loss as well. One of the most common things that we see is what's called a varicocele. So this is an anatomic finding. So the testicles are outside the body because they need to be cooler, and a varicocele is these larger veins. And sometimes if these veins are too large, it impairs normal temperature regulation in the scrotum, and that can warm things up and impair normal sperm production. So that's a very important diagnosis to make, because a lot of times that can have significant consequences. Sometimes we can't find any cause, so-called unexplained or idiopathic, and there's various forms of testicular failure due to different endocrine disorders, and you can see a host of other causes as well that we want to identify. So what's the goal of this extensive evaluation? Well, we want to improve reproductive outcomes, and we have some options to do that, both surgical and medical. Sometimes we can identify significant health problems. So by improving a man's reproductive health, sometimes we can also improve their overall health. And then also we want to motivate and engage men as well. Obviously, fertility is a team sport, so it's important for both members to be very active because they both do contribute. So if we look specifically at recurrent pregnancy loss, again, we know a lot about female causes, but we're learning more and more about male causes. So we know that male age contributes significantly to pregnancy loss. Male health and lifestyle. We know that men with hypertension, hyperlipidemia or high cholesterol, diabetes, being overweight, all those are significantly alter pregnancy trajectory. So lead to higher rates of miscarriage, stillbirth, and even preterm births. Varicocele, which we spoke about earlier, has also been associated with recurrent pregnancy loss. And for men that have those repaired, they've seen improved outcomes in live births. Different measures of semen quality, whether it be the number of sperm, the movement. There's also some other more advanced testing, such as something called DNA fragmentation that some of you may be familiar with. So as its name suggests, this looks at the fragmentation of DNA or nicks inside DNA. And sometimes while those sperm can still lead to fertilization, it leads to abnormal embryo development, which can lead to a higher miscarriage rate. So that's also important for us to note because there are things that we can do about that. And also there are male genetic causes as well, again, which we'll hear a little bit more about. So again, fertility is a team sport. And this is just a slide to remind me to talk about how as we age, both men and women, fertility declines. And so that's important to understand that this is a couple issue when they come in. And so if I see an infertile man with a varicocele, testicular failure, some semen abnormalities, it's a much different discussion whether his partner is 30 or 39. And so when we have our regular meetings about these different couples, when I talk to Dr. Lathi, Dr. Aghajanova, Dr. Chen, Dr. Byers, we do certainly take the whole couple into account as we're coming up with a treatment plan. So to summarize, male infertility evaluation is very important, and male factors can contribute to infertility, including recurrent pregnancy loss.
Really just want to thank the team in the Stanford Health Library. One of the questions on the chat was, will this video be available? We actually will be sending the video to email them to you if you opted into receiving that email, or it will be available at the Stanford Health Library. You can also go to that same website to register for our next 2 seminars. We've really only just scratched the surface for known causes of pregnancy loss tonight. We'll be delving into some of the unanswered questions and research topics in this field in our next seminar, which is exactly 2 weeks from today. And we hope you can join us for that. If you want to learn more about our clinic, this is the Pregnancy Loss Clinic is here at this website here. And then the last link is just the link to our research website. So if you want to learn more about our research, you can go to that bottom link there too. And then let's start with the Q&A. The first question is, what are our thoughts about acupuncture in regards to pregnancy loss, recurrent pregnancy loss, able to become pregnant and carry to term? I think this is one of the many unanswered questions in our field. Acupuncture is like a whole another study of medicine. I've seen it help many of my patients who are suffering from anxiety or depression or insomnia associated with pregnancy loss. I think that it can really help with some of the side effects of some of the medications we might be using, such as nausea or headaches. So we do see it as a complementary to some of our treatments. I'm not aware of acupuncture alone being used to help recurrent pregnancy loss patients, but we definitely lean on our partners in complementary medicine to help us with some of these side effects and after effects of pregnancy loss. Jayshree, another question was, what are the 3 foolproof takeaways for couples to follow for successful pregnancy? I would say, number 1, that don't give up, that miscarriage is common, and the vast majority of patients that have miscarriage and recurrent pregnancy loss will eventually succeed. So the number 1 predictor of success is investigating for underlying causes, and don't give up. For Dr. Aghajanova, a couple questions about the uterus. How small septum, sorry, oops, it's moving around. How small a septum should be considered normal, and does it cause endometrium thinning?
Can you guys hear me?
Yep.
There were other questions which I answered, so whoever is interested can look into the answered questions. So there is definition for us how we diagnose, how do we differentiate septum from arcuate uterus that I mentioned. So there are like measurements on ultrasound or saline sonogram that we do. And in general, septum is not associated with a thin endometrial lining. It can potentially lead to thin endometrial lining is if extensive surgery was done, septum was extensive, and then there's some sort of rescarring happened, but usually these are separate entities.
Okay, great. And then do you want to take the question about vaginal probiotics? Is it recommended to increase lactobacillus? Or do you want me to take that one?
You can take it, yeah.
Okay. We worked together side by side for so many times. So vaginal probiotics is an interesting question. We still don't have the definitive answer on that question. Certainly, we do see shifts in the microbiome that can increase somebody's risk of developing endometritis and miscarriage. How do we shift that microbiome back to normal is the real question. And an area of active study right now. I definitely encourage the vaginal probiotics for patients who are developing side effects from antibiotics because of the risk of yeast infection and other vaginal side effects. But, oops, my slide disappeared. But right now it's an unanswered question. I think it's no harm, especially if someone's having significant symptoms. Next question, I'll send this to Lucy. My baby was born 2 months early, but I had bleeding throughout my pregnancy. What are considered normal and abnormal bleeding during pregnancy?
So, to answer this long question shortly, bleeding is not normal during pregnancy. However, there are some situations when bleeding can happen and pregnancy still can continue and proceed. And depending on at what stage in pregnancy the bleeding happens, it can mean different things, right? So if bleeding happens at the early stage of pregnancy, first trimester, that can, but the pregnancy continues to develop, it can be, considered there's maybe a little bit of disintegration between, the early forming placenta and the maternal wall. However, the defect is not small and the pregnancy just continues. If, and then also another thing that, some bleeding during pregnancy can come not from the uterus or placenta, it can be just cervical or just, fragile cervix or some other issues. So every bleeding should be evaluated, but I'm really glad that your baby was born healthy. 2 months early is stressful. However, these babies usually are doing very well.
Yeah, there's a number of questions here about thin endometrium. Do you want to just say a few words about that, Dr. Aghajanova?
I haven't seen them. Do you want to answer the CD138 while I am scrolling down?
Yeah, so CD138, what we're doing at Stanford, this is a question about how do we know it's a plasma cell? Actually, our pathologists are looking with both types of staining so that we can identify plasma cells more specifically. So they stain with this traditional, what we call H&E staining that gives better architecture, and then also CD138. So they're overlaying two different stains. But really, there's no perfect test for this, and it is an area of controversy in our field that we're trying to sort out. I was just trying to combine a couple of questions, but okay, so because we are getting short on time, but we will try to answer a few questions. So there's a patient question here. I had 2
Okay.
miscarriages.
Yeah, I'll answer this. You can scroll down. So, you know, from what I'm thinking about, right, that maybe you developed Asherman syndrome or scar tissue in the uterus. That's the first thing I'm thinking about. I don't know exactly which test the REI performed. If REI performed hysteroscopy, like saline sonogram hysteroscopy, and didn't see absolutely no scar tissue, then, you know, we probably need to talk more about this. But usually, classically, if you don't have menses after DNC and you had regular periods and spontaneous pregnancy before that, no menses after DNC usually is associated with development of scar tissue, because DNC is one of the biggest offenders in terms of damaging the endometrium. Yeah, I mean, we do see this. We did come across with this kind of stuff, and definitely paying big attention to the uterus is, I mean, some hormones can help. Hormonal testing definitely can help, but doing hysteroscopy, I think is the way to go. I'm hoping you still have to do that.
Okay. What does Dr. Aghajanova think about ERA with IVF? Has she heard of the Receptiva test? If so, is it
Yes,
worthwhile?
we've heard of all of this, and Dr. Lathi actually pioneered the Receptiva testing here, so I want to give her credit for that. And we do use ERA testing in our IVF patients based on indications. Usually we use this mostly on patients with recurrent pregnancy loss, and in some other patients, we don't routinely use this on, sorry, not recurrent pregnancy loss, recurrent implantation failure. We don't routinely use this on patients with recurrent pregnancy loss because there's no data, right? We kind of really try to practice evidence-based medicine or do things that make sense. So we do test our patients with recurrent pregnancy loss with the Receptiva testing, because there was some data about that. It may help us to get some answers in some cases of RPL. So we kind of started doing that. Am I correct, Ruth? Like that's
we're doing it as part of a study as an adjunct to IVF right now. Receptiva, for those in the call who are not familiar with it, it is a test to check for endometriosis, which can be associated with both infertility and pregnancy loss. So for couples who are really struggling with both very difficulty to get pregnant and multiple pregnancy loss, this may give us a hint as to whether there's an endometrial cause. So in selected cases, I think we're seeing some hope there. I just want to see, there were a couple.
I'm going to go to Katie to question I think that we skipped. I just want to make sure that she.
Yeah, there's so many. I was trying to see if there were questions for, I think, Dr. Eisenberg, did you answer the mail questions already separately? Did they come off this chat?
Yeah, I did. They should be in the answered portion. So yeah,
okay.
And I've been answering the hematology ones.
Oh, okay. I was trying to give everybody a chance. Here, me and Lucy are chatting away here with everybody.
I want to answer a question for Katie. So Katie, this, from what I read, it does sound that you are probably falling into our good prognosis patients. You know, again, we cannot 100% promise anything, but from what I read here, I mean, hopefully you should be successful pretty soon.
Yeah, I hope so too.
Yeah.
The question we didn't hear from immunology side. Hopefully we can address that in a future seminar. Question about how long to wait after partial septum incision. What do you usually recommend, Dr. Aghajanova? How long to wait after partial septum resection?
If partial septum, which by this you probably mean like really small septums, we wait at least 1 month. We perform ultrasounds after this, and depending on how the follow-up ultrasound looks in terms of thickness of the lining and if septum does look resected, we can proceed with the treatment, with a subsequent pregnancy and treatment. We also sometimes, in some cases, do repeat saline sonogram at least, to kind of confirm that there is no scar tissue developed after septum resection, as well as septum has been resected.
Yeah. Okay. We'll do a couple more and then we'll just.
These are real life threatening.
Yeah. So
Yeah,
I think it's very traumatic. I think that if it's very difficult, but there are no causes of recurrent pregnancy loss that are life-threatening. And so it's really mostly confined just to the reproductive outcomes that we're trying to optimize for our patients. I think there was a question about adenomyosis. Is there a solution to miscarriages with adenomyosis? What do you think, Dr. Aghajanova? Would adenomyosis be a cause for a recurrent miscarriage?
There hasn't been a strong association made between adenomyosis and miscarriages, endometriosis and miscarriages. You know, there are some suggestions that can happen, but this is not an established link. So especially adenomyosis is cause for recurrent miscarriage hasn't really been established, because by the time women develop really significant adenomyosis, that usually happens in the older reproductive age. So then, you know, you already have aneuploid and abnormal embryos as one of the main causes for adenomyosis. If for recurrent pregnancy losses, if you have euploid embryo and you do IVF and the embryo is euploid and you have adenomyosis, then we may potentially think about this and try to address adenomyosis issue.
Okay. Okay. Well, we have
question.
Go ahead. You want to answer one more? Go ahead.
Yeah, 3D hysteroscopies and now thin lining. How do you typically think about how much trauma can uterus take and rebound for future pregnancies? You know, it's very individual, right? I think that there potentially this what I'm saying is not really based on any scientific research because there's none, but I do feel that some uteri potentially can take more than others. You can see that somebody develops thin lining and scarring after one DNC while someone goes through 3 DNCs and nothing really happens. So there can be potentially, I don't know when and who will do this research, some genetic predisposition to better healing. So, so it's really difficult to predict, but we do know that DNCs postpartum or after miscarriages are associated with endometrium. So when things are in our hands, we are actually trying to be very gentle and now kind of even trying to start new wave of managing how we manage post-operative period after DNCs that we perform so that the uterus can rebound easier potentially for future pregnancies. Yeah.
Great. Okay. It's going to be really hard for us to get through all of these questions. Have there been studies that demonstrated that triggering an immune response by vaccine or illness prior to ovulation can result in aneuploidies? None that I'm aware of. What I've seen from my understanding is no, we haven't seen an immune cause for chromosome abnormalities in pregnancy losses. Most of the chromosome abnormalities that we see in eggs or miscarriages are really a result of this non-disjunction that when the egg is forming, and any sort of immune reaction after the pregnancy is established won't impact the chromosomes. If a frozen transfer cycle with estrase, what can be the cause of endometrium lining to increase from 7.5 and then decrease to this pattern was observed in 3 consecutive cycles? Gosh, I think we're never going to know the answer to that question. Both Dr. Aghajanova and I have probably seen that in our patients, that perhaps there's a kind of a downregulation of receptors. If you're on estrogen that's too high for you or for too long, we start to see diminishing returns or even potentially a negative impact of too much or too long of estrogen. So typically what we would do in a case like that might be to start at a lower dose of estrogen and gradually go up, or try a different route, like instead of tablets, try patches or something like that, because everybody's body's going to react differently.
But we really don't know.
We really don't know, but we try something different. I've heard there are 2 markers to check for subclinical endometriosis based on a biopsy. What are your thoughts regarding this? Yes, there's actually, this is an area of active research over the last decade or so, trying to figure out a non-surgical way of diagnosing endometriosis. Beta-3 integrin receptors was the first one that had some predictive value in endometriosis. Now we've found that the BCL6, a newer marker called BCL6, which is the main component of the receptiva diagnosis test, seems to be a stronger correlation or more likely to be associated with endometriosis. And actually, as Dr. Aghajanova alluded to, we are doing some research to see if we can find more precise and predictive markers of endometriosis and implantation failure. So this is a study we'll mention in our next webinar. You can also find out a lot more about it if you just go to our website, if you want to hear more about that study. We're trying to answer some of these questions as fast as we can.
I'll take next ones, I read them. So is a very light menses a problem when doing IVF? Well, you know, when people report light menses, we take, you know, kind of a note of that, and we evaluate the uterus, pay attention to uterine lining and thickness, right? Because light menses, especially in a person who previously had normal flow, now light menses can be associated with thin lining or uterine scarring. So that's basically what we're thinking about it, evaluating. If the evaluation is normal or endometrial lining is normal, is of normal thickness during IVF cycle, then light menses can be just, you know, the flow that you get. How common is uterus scarring after one successful pregnancy? I have a healthy 6-year-old, but 3 pregnancy losses in the 1 year. I'm sorry to hear that. It's pretty stressful. But usually after successful pregnancy, in terms of if pregnancy and delivery was normal, which means you didn't have any excessive bleeding that necessitates, for example, uterine curettage. If you didn't have infections, postpartum infections that will, you know, kind of by itself cause uterine scarring, then successful pregnancy should not be correlating with uterine scarring. It's pretty uncommon. So pregnancy losses, on the other hand, potentially, especially if you have DNC, can result in uterine scarring.
Okay, well, I know we're way over time now, and I really want to thank the Stanford Health Library for hosting us tonight and all the participants for their attention and their fantastic questions. We're really sorry that we couldn't answer all of the questions tonight, but what we'll do is we'll compile these questions and answers, and we'll work with the health library to get all those questions answered for you in the next week or two before our next seminar. Again, thank you so much for your attention, and we hope to see you at our next webinar in 2 weeks. And if we continue to have great response to our first 3, I promise we'll put on some more later in the year, because we love hearing from our patients and doing whatever we can to answer your questions and give you the information you need to make your decisions moving forward. So appreciate your attention. Just know that we are all here for you, and we want to help you however we can. And these are the ways you can get in touch with us. So thanks again.